Hi everyone, my name is Bruce Bassey. I'm a psychiatrist with Telepsych Health. Today we're going to be talking about anxiety. So what is anxiety? Anxiety is a normal feeling. Just like sadness or depression, there are instances where anxiety can be completely appropriate to a particular situation. One of the biggest criticisms of psychiatry and the field of psychiatry in general is that people over-medicalize and pathologize certain symptoms. And so while people do have certain feelings of anxiety present on a day-to-day basis, that doesn't necessarily mean it's a disorder. Doesn't necessarily mean we have to do something about it to treat it. When it gets to the point of being a disorder is when it's debilitating you and preventing you from functioning. And that is preventing you from functioning on a day-to-day basis, more days than not. And it gets to the point where you're not living the life that you want to live. So if you find that it's pervasive and unending, then it gets to a point where you feel like you need to seek treatment for the anxiety. But anxiety itself is on a continuum. So you can have normal fears of a completely normal nature, such as from an animal. I know people probably heard this before, but there's a kind of an evolutionary reason for people having anxiety in the first place. And it was protective at one point. So anxiety was protective at one point for survival. That fear of being eaten, that fear of fire, fear of falling off a cliff, fear of dying of starvation. And that worry and anxiety drove people to find food and to seek shelter and to protect their family and loved ones. And so evolutionarily, there was a benefit to anxiety, but then there becomes a point in our society where it is triggered and we are kind of misrecognizing the wrong cues for triggering anxiety. So instead of that bear or that fear of falling off a ledge, which are inherent pre-programmed feelings for anxiety, we're being triggered by just speaking in a completely friendly, benign situation to certain people. And so there's a lot of different diagnoses for anxiety with the DSM. So there's generalized anxiety disorder, which is a symptom of anxiety, worries for at least 6 months with at least 3 out of 6 comorbid or co-occurring, coexisting symptoms at the same time. We'll talk more about what those symptoms are. And then there's also panic disorder, where people have a really rapid onset of fear of being out of control, fear of losing control, fear of dying, like a panic attack, and that it's usually not precipitated by something, and it's completely unexpected and out of the blue. And so if there is a preceding factor, usually it is just a phobia related to that certain factor. For example, if you have a panic attack related to being in an airplane or flying, then it would be a fear of flying, according to the diagnosis of what psychiatrist might put in the chart. Then there's also social anxiety disorder, where people have fear of interacting with other individuals, or fear of speaking with other individuals, that fear of judgment. Generalized anxiety is more pervasive throughout people's day. So when an individual is also by themselves, and that would be one differentiation, one way to differentiate between social anxiety disorder and generalized anxiety disorder. If you have that sense of worry and anxiousness when you're by yourself, that would be a little bit more supportive of generalized anxiety disorder. I talked a little bit about generalized anxiety disorder, social anxiety disorder, panic disorder, and then there's also PTSD, which can be anxiety that is due to a prior trauma. And the lifetime prevalence of these disorders is between 5 and 12%. So generalized anxiety, about 5.7% of people will have that symptom or that disorder at some point in their life. That doesn't mean you're broken or you're unfixable, but at some point you had met the criteria for that disorder. And like I say, when people are really struggling and grappling with that label, I tried, not to have people over-identify with it and don't think of it as a label, but a way to really align yourself with other individuals with similar symptoms, and a way for you to get the right treatment for those symptoms. So regardless of what we call it, generalized anxiety, social anxiety, panic, these are ways for you to determine what other people are going through similar symptoms as you. And so in terms of generalized anxiety disorder, between 5 and 6% at some point in their life will develop symptoms of generalized anxiety disorder. For social anxiety disorder, it's about 12.1% of people. Panic disorder, about 5%. PTSD, about 6.8% of people. So what are the DSM-5 criteria for generalized anxiety disorder? And it can be difficult for people to recognize these symptoms. These are really from self-report and from a clinical picture. There's not any sort of lab test or uh, imaging test to determine generalized anxiety. So it is defined as a period of excessive worry and anxiety for more than 6 months persistently, and there's difficulty controlling the anxiety, and then there's at least 3 out of these 6 symptoms. So there's restlessness or feeling keyed up, being easily fatigued because it is really draining to have your mind racing all the time and self-evaluating constantly. Difficulty concentrating, of course, if you're trying to focus on a task and you're anxious about performing that task, you're not going to focus on whether or not you're going to be doing it correctly. And also if you're in a conversation with somebody, it might be difficult to speak your mind freely and your mind might go blank. So difficulty concentrating, key component of generalized anxiety disorder. Irritability, because people are really tense. Muscle tension is a 5th one. And then sleep disturbance, which can either be difficulty falling asleep, staying asleep, or unsatisfying sleep. And so these symptoms have to be causing clinically significant distress or impairment. So these symptoms have to be causing clinically significant distress or impairment. And what that means is that if you're going to a therapist or seeking help by a psychiatrist, then it usually has reached a point where, unless somebody is telling you to go to the hospital, it probably reached a clinically significant period of distress or impairment. So generalized anxiety, I'd mentioned between 5 and 6% of people may meet the criteria for generalized anxiety in their lifetime. And it's more prevalent in women than in men in a 2-to-1 ratio. The mean age of onset is in adolescence, and so that's important to keep in mind. People can have an age of onset in their 20s, so it doesn't necessarily mean that you have to have had these symptoms your whole life, but often they're prevalent or present in a more attenuated state in childhood and worsen when people go throughout various parts of their life in their late teens and 20s. It's the second most common psychiatric disorder after depression in primary care. There's an 8% point prevalence in primary care. So if you take all incoming individuals to primary care, about 8% of people will meet the criteria for generalized anxiety disorder. So generalized anxiety is under-recognized by patients, and so people typically have symptoms for about 10 years before seeking medical treatment, and that's from Olfson et al. From American Journal of Psychiatry in 1998, and also we call GAD for short. Generalized anxiety is under-recognized by physicians, so only 34% of patients are diagnosed correctly by a primary care physician, which I think is kind of surprising because in psychiatry, sometimes it's mistakenly thought of as a catch-all diagnosis for somebody who's just pretty anxious. They'll most likely have fit these kind of abstract symptoms of restlessness, irritability, feeling keyed up, fatigue. And so I think probably in psychiatry, it's more highly diagnosed than that. GAD is undertreated, so only about 20% of patients who currently have the diagnosis are receiving proper treatment for it. And also, achieving remission in GAD is actually pretty difficult. Very few patients achieve a complete remission in GAD. So what causes anxiety? So there are genetic influences that prime us to have more sensitive fear circuitry. And the fear circuitry is comprised of the sensory cortex, which is inputting all of the hearing and visual stimuli. And then that comes into the thalamus, which gets sent to the anterior cingulate, and the amygdala, which is responsible for that fear response, the hippocampus, which is responsible for tying that to prior memories that you've had of that situation, and then the prefrontal cortex, which is tries to put the brakes on these sorts of symptoms. So you can have these environmental or epigenetic influences, such as in your upbringing or your during your mother's pregnancy actually have some correlation to GAD disorder when that baby grows up later in life. And then you have not only this disrupted or really primed fear circuitry, but a disruption in core psychological processes. So you have a biased threat appraisal. You think of a certain threat as being more threatening than it should be. And so you might take a neutral stimulus, and while it's typically just considered that and a neutral stimulus, but in particular in somebody who has PTSD, for example, that individual might be cued by that previously neutral stimulus. And so you have an enhanced fear conditioning and a resistance to the extinction response. And so instead of instead of encountering that situation multiple times and having those symptoms become extinct or lessened over time, there's a tendency towards resistance of that. So to recap the neurobiology of anxiety, you have these threats coming into afferent pathways of the sensory cortex, and then you have that going into the thalamus, which gets sent out to the cingulate, into the hippocampus, to determine if these are really salient. And then from there, it goes into the amygdala to really create and process that fear response. And that's when we tend to perceive the anxiety. The neurotransmitters in these pathways are multiple. And so there's GABAergic neurotransmitters, there's noradrenergic, serotonergic, and glutamatergic neurotransmitters linked in these pathways of anxiety. And so it's not just one neurotransmitter. The serotonin gets the vast majority of the claim to fame and the recognition of anxiety, but there's others, GABA, norepinephrine, and glutamate. So why is recognizing and treating generalized anxiety disorder so important? Because it has such a big burden on our economy, and not only you, but the economy as well. And so there's a lot of lost time. People actually miss an average of 6.3 days of work per month worldwide. And when people are at work, there's lost productivity. And so 11% of individuals report a 50% decrease in productivity due to generalized anxiety. And like I mentioned, one of the criteria for generalized anxiety is that difficulty concentrating. In one survey of primary care patients, about 21.9% of those patients with GAD were actually unemployed. So that gives you a sense of how difficult it is for those individuals to keep and maintain a job. Generalized anxiety disorder also diminishes individuals' quality of life. And so when you compare individuals with GAD to healthier controls, people with GAD are more likely to report a poor sense of overall well-being, dissatisfaction with their job, dissatisfaction with family life, and increased worry about minor matters, which impair social functioning and close relationships. And also that sort of impairment in social functioning can create more stress among family members. And people with GAD have a higher state of vigilance and arousal from emotional situations. So they have a high sense of emotional reactivity in certain social situations. And so that makes people also pretty keyed up and pretty stressed out among family members. Chronic stress exposure also has medical consequences. So that can increase the hypothalamus pituitary axis activation, which leads to hypercortisolemia and increased cortisol production, increased glucocorticoid disruption pathways, and there's difficulty to shut off that axis, which can lead to hypertension, coronary artery disease, obesity, and so these are all linked to that high level of cortisol. So cortisol is usually related to high levels of stress. People who have generalized anxiety disorder have a lot of stress, and that's how that's the link there from anxiety to hypertension, or anxiety to artery disease, or obesity, type 2 diabetes, and high cholesterol. And in terms of psychiatric comorbidities, individuals with generalized anxiety are more likely to have bipolar 1 disorder or social anxiety. So people with generalized anxiety are more likely to have some sort of other co-occurring psychiatric condition. It doesn't necessarily mean you only have one label, one condition. You can have, because these labels and conditions are man-made and artificial constructs. And so you are more than just that label. And you can fit the criteria of the artificial construct for more than one disorder. And this goes to tell us that people with generalized anxiety also have a lot of other features of other types of disorders that we need to look out for and address and get treatment for. In terms of one of the more important co-occurring symptoms, which is major depressive disorder, people with generalized anxiety have a higher risk of developing major depressive disorder. Anxiety often precedes depression and it increases the risk of developing depression. It also increases the risk of relapse or persistence of depression. So unfortunately, generalized anxiety disorder is a clinical diagnosis. We rely on self-report of an individual having those symptoms for more than 6 months, at least 3 of those 6 symptoms. And so the diagnosis of GAD can be very challenging. And so recognition of the diagnosis in clinicians improves when people recognize that the anxiety can also help explain some sort of somatic symptoms, physical symptoms that people have. And you can use some screening tools that might assist in detecting hidden anxiety, because it doesn't always come up when you're visiting your primary care doctor, for instance. You're not going to have enough time to talk about all your anxieties and worries, and that doctor is not going to go through the DSM criteria. So there are some screening tools that you can use. to see if you do fit the criteria for this diagnosis. So what are some primary reasons that patients with generalized anxiety disorder come to the doctor or come to a physician, come to a provider? And so 48% of the time, it's actually due to somatic complaints, so physical sensations. And people with generalized anxiety are really highly attuned to bodily sensations. And so they'll be overanalyzing certain physical symptoms and thinking that they have a problem with one of them. And so that will bring them into the doctor. Or it could be pain. And so people with coexisting pain and generalized anxiety will also often perceive their pain to be worse than if they didn't have any sort of anxiety whatsoever. It also could disrupt people's sleep. They could come to the doctor for depression too. And so, but it's important to keep in mind that somatic complaints is actually one of the chief reasons that people present to a doctor who have anxiety. So it's not like they're coming to the doctor for anxiety in particular. They actually might come to the doctor for physical symptoms. And so that can also make the diagnosis a lot more difficult because you're already going off on the kind of the wrong pathway there. And that kind of explains why individuals with generalized anxiety disorder do utilize healthcare services quite a bit. So I mentioned that people with generalized anxiety disorder are high utilizers of healthcare services. And so that can lead to a lot of unexplained symptoms because they're so primed in overanalyzing their physical sensations. And so they think that they constantly have an illness, they're going to be constantly going in to see a doctor. And so you have what's called negative anticipatory thinking. So if you're already thinking that you have a problem, you're going to go to the doctor already perceiving a problem, you're going to be more likely to be diagnosed with a problem. You'll have uncontrolled worry about ordinary day-to-day things like family, money, and illness. And you might have a much larger medical workup with multiple tests, cardiac tests, GI tests that all come back negative. And so you might have certain physical symptoms that come back as atypical types of pain or undiagnosed GI symptoms that the physicians have done a huge, pretty thorough workup, but can't figure out any sort of cause for. That's a pretty prime example of an individual generalized anxiety disorder. So we mentioned that making the diagnosis of generalized anxiety disorder is important. And the reason that it's important to make the diagnosis is to get you on the right path for treatment, because the right treatment can improve your quality of life. So having the diagnosis of generalized anxiety disorder doesn't mean you need to live with all of the issues and the impairments that comes with it. And so if you get on treatment, you actually can improve your quality of life, you can improve your workplace productivity, and you can reduce your risk for developing depression or other sort of psychiatric comorbidities. And you can also reduce maybe your yearly deductible, and so reduce any sort of wasteful healthcare expenditures. So what is the main goal for treatment? So the main goal I mentioned earlier is that we're trying to restore function. We're not trying to eliminate the symptoms because it's impossible, not likely, not feasible to eliminate symptoms. Nobody is going to ever be anxiety-free. And so you have to recognize that you might have to get to the point where you're going to have mild symptoms of anxiety. Everybody will have those. And you'll have to continue to go about your day-to-day life. And so that is the primary goal. If that's what you make as in your mind, your primary goal for treatment, you're going to do much better. So restoring function is the primary goal. We want to reduce symptoms. We want to reduce our interpretation in that high priming state of anxiety. We want to eliminate any sort of phobic avoidance of particular situations. We want you to be able to go about your day-to-day life in a way that you're happy with the things you're doing. And you want to restore your ability to carry out everyday activities and work and family and recreation. And that overall, that elimination of symptoms of anxiety, that elimination of phobic avoidance, and ability to restore, ability to carry out your everyday activities will lead to a functional restoration. In terms of medication options for pharmacotherapy for treatment of generalized anxiety disorder. So first-line treatments options are duloxetine or Cymbalta, escitalopram or Lexapro, paroxetine or Paxil, pregabalin or Lyrica, sertraline or Zoloft, venlafaxine or Effexor. And so these are all options as a first-line treatment. And so when you're on one of these medications, you should make sure you're on them for at least 6 weeks and at a therapeutic dose. And so your psychiatrist or nurse practitioner will know what is a therapeutic dose. So it's not enough to just take it every other day. These are medications that you need to take daily. You need to take them for at least 6 weeks, and you need to take them not just at the starting dose, but at the increased dose that's a typical therapeutic level, because the response that people have to these medications is dose dependent. And so it's not enough to just be on the starting dose for 6 weeks. You need to if you're tolerating the medication well, go up to the next level, the next dosage. So I mentioned the first-line treatments for medication options. And when an individual is going through an acute, really severe episode of anxiety, people can be started on benzodiazepines. It's recommended that the benzodiazepines are used short-term as a way to bridge people onto the SSRIs or SNRIs, which are the medications I mentioned earlier, because the benzodiazepines can cause some cognitive deficits, memory impairments, some disinhibition, and they can lead to some reinforcing properties, so people can feel somewhat of a buzz effect on them, and that does cause some reinforcement to have addictive properties for the benzodiazepines. So they should be used in a short term, maybe 2 to 3 week duration, while the SSRIs and the SNRIs or the SNRIs are coming on board and getting up to that therapeutic level. So other options while you're waiting for the medications to start to take effect are doing CBT, which is also first-line treatment. And there's studies that show in the British Medical Journal of Psychiatry that CBT is actually better than placebo or waitlist. And so people will be divided up into getting just placebo therapy or just staying on a waitlist to get CBT. And they actually found that CBT is better than those other two categories. And so internet-based or computer-based CBT is also effective. It is more durable and duration for treatment rather than the medications, which can, you can find that your symptoms come back after stopping the medications. And so if you do CBT, the effects is more durable up to 24 weeks. Sometimes people do need to go back in to see a therapist just to kind of refresh themselves on certain CBT techniques. There are a few other types of psychotherapy options, such as metacognitive therapy, acceptance-based therapy, short-term psychodynamic therapy, or you can use interpersonal therapy, motivational interviewing, or simply exercise as a way to help treat anxiety. For individuals who have been started on either an SSRI or an SNRI, or have already started CBT, you would first wait 8 weeks. I mentioned 6 to 8 weeks of treatment to see how people do. And so if you're responsive to those types of treatments, in 6 months to 1 year or so, you will reevaluate whether or not you should be on the medication or if you need to have booster sessions of CBT. If your symptoms did not reduce and you are considered to be non-responsive to that medication, so one thing you would do is try to switch the medication to another first-line treatment. You might want to reassess the diagnosis. You might want to examine for any sort of comorbidities like prior trauma. You should assess for treatment adherence. I mentioned that the medications need to be taken daily. Assess for adequate dosage. I mentioned that the medications need to be up to therapeutic level and not be on a introductory starting dosage. And so there are other options that people can try if the medication that was first tried isn't working. So augmenting the medication with CBT or augmenting it with a benzodiazepine or with a low dose medication of an antipsychotic medication. So some antipsychotic medications such as Abilify could be helpful, olanzapine, Seroquel, which is also called quetiapine, or Risperdal. So these are third-line medication options as an adjunctive therapy to be used in addition to an SSRI or SNRI. And so these are decisions that a psychiatrist would be able to make with you. A couple of other really effective therapeutic techniques for treating generalized anxiety. I mentioned that CBT is very effective and has a lot of data in support of CBT for generalized anxiety disorder. And a couple other options are positive psychiatry, and I'll get into that, and also resilience training. And so positive psychiatry basically involves 10-minute evening mental exercises of thinking about something that was pleasurable or fun or brought joy to you or amusement to you. And so you would basically, at the end of the day, check in with yourself and reflect and write down 3 things that you have experienced and describe how you felt. And so you'd want to find something that was actually pleasurable for you. So the idea in positive psychiatry is to re-engage your mind and focus your attention more on positive aspects of your life that are probably all around you in certain relationships and accomplishments. But when we're really caught up in our own mind with generalized anxiety, we don't really focus as much on those positive aspects of our life. So checking in at the end of the day and actually writing this down can be really helpful and kind of realign and refocus your vision on the really positive things around you. I mentioned the other type of therapy is resilience training. And so there are certain factors that can promote resilience, and having high levels of resilience are actually associated with lower levels of anxiety because people are going to get through really stressful and difficult times with more grace and more optimism. And so there's certain traits that people can really hone in on and tend to cultivate. And those traits are optimism, cognitive reappraisal, and so rethinking about your current situation or your current life, active coping strategies with other sorts of friends or family members or other support or a pastor, using humor as a mature defense mechanism in order to promote resilience is really helpful. Using physical exercise, certain types of pro-social behaviors. So doing something that's good for humanity and good for our society actually brings more resilience and more joy to us. It actually promotes positivity in our own mind when we bring joy and goodness to other people. And also doing some sort of mindfulness or meditation can promote resilience. And so you're bringing down that overall level of stress. And so when you do have these little blips of stress that are encountered throughout your day, you've already practiced and honed in on those sorts of exercises and techniques that you can fall back on. Some of the difficulties with treating generalized anxiety disorder, and I just really skimmed the surface of a lot of these topics because there can be a lot of controversies about the medications. There's a lot of stigma with them, and there's not really any sort of clear guidelines about which particular agent is going to be best for you to use. We do have some ways to determine if you're a slow or fast metabolizer, but we don't really know yet which is the most effective medication for you specifically. I think that the best approach when treating generalized anxiety disorder is to really embrace a multidisciplinary and multi-pronged approach. And so incorporating medication options with a psychiatrist or nurse practitioner or physician assistant, really establish that relationship with a very trustworthy therapist, and doing CBT or doing positive psychiatry or resilience training. I hope that this video was helpful in describing the signs and symptoms of generalized anxiety disorder and just touching and skimming the surface on treatments for generalized anxiety disorder. It was a pleasure talking to you about this today. Again, my name is Bruce Bassey with Telepsych Health. I see patients in multiple states around the country via my online platform at telepsychealth.com. And thank you so much for listening. And if you enjoyed this video, please subscribe and like below. Thank you.